We are live now, doctor.
Thank you. Good evening to all. Dear guest speaker of the today's session, Dr. Christine Carol Nelson, and the convener of the today's session, Dr. Usha and Santosh, and panelist, Dr. Shruti Vijay, and Dr. Manik Shah, and my dear friends from TNYA, Dr. Arulmaju Varman, the president-elect, and Sriram Gopal, the secretary of TNYA, and Dr. Balaji Treasurer, and Atik chairman, and Ravi Kumar, and Madhura Gopal, and Prasanna, and all other friends, and dear delegates. Warm good evening to all of you. Today we are very fortunate to have Dr. Christine Nelson as our guest speaker for the session on lead tumors. Every month, you know, the Tamil Nadu Ophthalmic Association is conducting various academic activities. And of course, all of you are very well know that we are having one international guest speaker for every month. And this month we thought we can have a lecture on orbit, there's lead tumors and its management. So immediately Dr. Usha mentioned about the name of Dr. Christine Nelson, who is the head of the Department of Orbit and Oculoplasty in Kellogg at the Mexican University. I don't need to say about Christian because he is a very well-known person in the field of orbit and oculoplasty. Dr. Usha will be introduced her to all of us, and definitely this lecture will help us to manage our patients with this type of lesions very well. And I have gone through her CV. It is a very long CV, and she is in the field of oculoplasty in the orbit for more than 30 years. And also, he has published so many papers, and not only orbit and oculoplasty and other things. I'm very much surprised to see such a very long CV and so much of credential in their thing. And also, I'm very happy that I am also in my early days, in 1989, I was doing orbit, little bit of orbit. Usha knows that, and I was first trained by Dr. Free in Kellogg. I was with him for 1 month in 1899. So I'm very happy that you are also belong to that same family. I once again welcome you because we have wonderful people in orbit and oculoplasty in our country. Definitely, this will be a wonderful session, and it will be useful for all of us. And of course, before going to the session, I request our Vice President to say a few words before handing over the mic to Dr. Usha. Dr. Arul. Dr. Arul.
Good evening, sir. Wonderful that you're doing this on month. To address us on lid tumors is heartening, and look forward to hearing and learning from her. Thank you so much, sir.
Thank you. Without wasting much time, I request Usha to take over the session. And also, I welcome all the panelists of this wonderful session. Yeah.
Thank you very much, sir. It's a pleasure to have this session. It's not a very common session to have, but we thought it would be a very useful session. So thanks to all the office bearers, President, Vice President, the ARC, the chairman, scientific chairman, secretary, I think he's on the road. And I think thanks for this vibrance. We are having month-on-month sessions like this, which is going to be very useful. I must thank our guest speaker, Dr. Christine, who very readily accepted this, this request. And thanks to Divya, who's been helping her out at the other end. And we have our esteemed panelists with us, starting with Dr. Senthilnathan, Dr. Shruti Senthilnathan from Rajanai Clinic and his own independent oculoplasty practice, Dr. Shruti from Shankara Eye Hospital, Dr. Vijay Rangarajan from Coimbatore Arvind Eye Hospital, Dr. Manaksha from Tirunelveli Arvind Eye Hospital, Santosh Honava from Center for Sight, and I am Dr. Usha Kim, as you all know, from Arvind Eye Hospital, Madurai. Now, it's been my pleasure to be contacting Dr. Christine for the past couple of days to have this session on lid tumors. Before we go into the session proper, it's a long introduction, but I'd just like to introduce her in the right way. She has done her fellowship in neuro-ophthalmology from Bascom Palmer. She's done her oculoplasty fellowship from University of California. She's done her postdoctoral fellow clinical visiting research fellow at Moorfields Eye Hospital. She's a research associate, Smith Kettlewell Institute of Visual Sciences, San Francisco. She's had a lot of grants for doing some non-communicable eye disease research in India. And she's been interested in Graves' ophthalmopathy. She's been doing a lot of work in that. But what's most touching and heartening is her work in retinoblastoma in Ethiopia. That's very dear to her. She's won a lot of awards. It'll take the whole evening for me to finish the list, but I would like to quote a few. She's had the permanent honor roll for the Ecole International de Geneva, Switzerland, the national award. She's been the Senior Achievement Award winner from the American Academy, the Volunteer Physician Award for services since 1985. She's had the outstanding contribution as an examiner to the American Board of Ophthalmology, the Van Hughes Lecture Award, Best Doctors in America for many years. Then she's got the Katowice Pediatric Award. She's one of the board of directors for the World Association of Eye Hospitals. She holds leadership position for the American Society of Ophthalmic Plastic and Reconstructive Surgery. She's she has the fellowship. She is the present fellowship curriculum project committee of the ICO. And then she also is the foundation board of trustees of the ASOPIS as well. I think the list is too long. I'm a little tired of reading out your honors and your awards, Christine, but may I invite you to give your lecture on tumors of the lid. The panelists are here to listen to it, and you can raise your questions once she's done. We also have another lecture after Christine's by Dr. Santosh, who will be talking from the Indian perspective. But most important, we will be dealing with the tumors of the lid and management by Dr. Christine. Over to you, Dr. Christine.
Oh, thank you very much, Dr. Kim. It's such an honor and pleasure to be here. I have the American perspective, but I'm very anxious to hear the other speakers and comments to learn more from all of you and enjoy this camaraderie and collegiality with you, Dr. Kim. It's hopefully going to grow into an even bigger collaboration. And Mr. President, I'm honored that you were here and hope we get to enjoy some more learning together. Thank you very much for inviting me to this meeting. So I think I'm going to go here first. Is that right?
Share screen.
And then go back to Zoom.
Share the screen.
Share my screen.
Taking that.
Oh, yes. And share.
Full screen. Full screen.
There we go. Does that come through well for you?
Perfect. Perfect, Christy.
I'm just sort of off to the side. So we'll just start at the beginning. I'm having wonderful help from your colleagues over here, because as I tell my patients, I do medicine, not technology. But let's get started for a wonderful evening of sharing. We're going to just start by talking about the most common lid lesions and that can extend farther. And these are the basal cells. And basal cell we think of as fairly innocuous, but it can become a huge ulcerating defect. This is one, oh, it's advancing on its own. If it's left untaken care of. So this we see on the lower lid, and this is behind his ear, ulcerating down onto his neck. But then you can see a basal cell that's quite small and could be easily missed, but often has symptoms maybe of itching. Other things that we see on the lid that are benign, we don't have to worry about, is this peculiar lesion here, which we biopsied and it turned out to be a dermoid cyst, cells that, as you know, weren't able to migrate out to the epidermis and got caught underneath the skin. Here we see with the blue arrow a compound nevus that the patient was concerned about, but we chose to follow. So in general, the guidelines we think of and the goals of this talk will be because of the increase in malignant eyelid and periocular tumors that we've seen over the 30 plus years that I've been in practice. Most are benign, most of the benign and malignant lesions are derived from the epidermis and the adnexa, and you want to identify and remember the characteristics and symptoms of malignancy. If you're suspicious, you can never be wrong with a biopsy. And then at the end of the talk, I'm going to give you a brief highlight in some new research programs we have in telemedicine. And I'm interested to see if you already are ahead of us on this and doing some other projects. So let's get going. We'll start with benign epithelial tumors. Most of the benign tumors are just from the epidermis and are diagnosed by just looking at the lesion. We look at them and we realize what they are. We have a keratoacanthoma on the left here and an inverting papilloma. We just saw this is just a benign papilloma. It's going without me, I'm sorry to say. So this is our little papilloma. We can just think of what it is when we see it pop up, and then you can check with the wording if you think of that as a keratosis. Then this is an actinic keratosis, more from sun, and this is a inverting follicular keratosis. So we'll move on to some other adnexal benign tumors. Whoop, whoop, whoop. Getting away from me. These are some sweat gland tumors in this patient here, the hydrocystoma, and you can get multiple ones of these from the eccrine sweat glands. So we need to think about when we want to worry and when we think it's just benign and we don't have to worry. If you see loss of lashes in an area, we worry about that, or even just thinning of the lashes. Itching is the most common symptom the patients present with. We get lid margin injection. I'm sorry about this going without me. And then we can have a chalazion that can occur if it occurs in the same location. The first time I don't biopsy it, but the second time I do. Ulceration and bleeding is always worrisome, as is loss of the lid margin architecture with loss of the meibomian glands. So what are the most frequent malignant tumors of the eyelid? Basal cell, at least in the States, is at 90% of our lid tumors. Squamous cell falls way down to 7%. And as you see, thinning of the tumor, loss of the lid margin, sebaceous cell and malignant melanoma. Malignant melanoma has grown significantly and surpassed sebaceous cell carcinoma. We'll go into more details on this, and this is a Merkel cell tumor, which is quite rare. The locations of the tumors, most are in the lateral canthus. We think of maybe we get more exposure there. The upper lid can be 10 to 15%. Medial canthus around here we think is maybe 20% because patients don't put their sunblock or don't use sunscreen in the medial area. Then the lower lid is 50% of all the different tumors. Squamous cell carcinoma is more common on the lid margin, like we saw in that last slide. Sebaceous cell, more common in the upper lid, but it tends to just grow and go around the canthus and extends way past where we can see. So here is a basal cell, some of the characteristics of malignancy with pushing the lashes off, very clear with telangiectatic vessels. Here we see loss of lashes and thinning and complete loss of the lid margin. Meibomian glands, gray line, complete loss of the lid margin architecture. Typically, malignants will be more irregular. The basal cells can be fairly round or oval and have distinct margins. So here are some different slides of how a basal cell can present. We don't often think of it being quite so insignificant. This may be a little more typical down here on the right lower corner where there's the pearly raised borders and a little ulceration, but this one seems fairly innocuous looking. So if you're ever suspicious, you always want a biopsy. Now with basal cells, you can also have the basal cell nevus syndrome, which is autosomal dominantly inherited with a very high penetrance. And we see this patient who's had clearly just multiple basal cells. We were concerned about these two new areas, and it's a lifetime of taking care of these patients. The other systemic findings are mandibular bone cyst on X-ray and palmar pits. You can look at their palms and see these pits that we see. This is another basal cell younger patient that I've been working with for a long time. He's had basal cells in a variety of different ways, places rather. And this is after a Mohs excision. We'll see more on treatment where they've excised it, and then we'll do the reconstruction here. Here's the same basal cell nevus patient with 3 different lesions that all connected in the medial canthal area. It's very common in these just to go from one basal cell into the next one, and they tend to connect. So he also had a bunch of basal cells up in his scalp and hairline. They form all over. So some of them can be very benign looking, but then that lesion can extend quite far. So you can even get, speaking of extending far, some of the medial canthal tumors can extend into the orbit and be much more invasive. And patients may think, oh, it's just a basal cell or a squamous cell, it's a skin cancer, and I don't really need to treat it. But you can see how this patient, it eroded right down to bone with the whole, this is a prosthesis covering the cheek area, and clearly it's in the orbit, pulling her eye down. So this is a very extensive involvement of the orbit. And sometimes it's because the patient is too ill to be treated or chooses not to be treated. So we saw this patient with a very extensive basal cell on his eyelids and cheek. And we think of squamous cell being more aggressive, but basal cell is more frequent and so can often also invade into the orbit. So if sometimes the earliest symptom we have the patient complain about is diplopia, and it can be an extreme gaze, or in this patient, clearly she would have diplopia because the eye is being pulled down with the inferior orbital involvement. So here's a relatively big tumor that was an older patient. The lid was fixed to the rim. She didn't have diplopia, but she didn't want it fixed, and we were concerned because we already knew that it can involve the orbit and get more and more complicated. So we talked briefly about itching as the most common symptom, but some of the characteristics we worry about in malignant lesions is the bleeding. Sometimes with the itching, they're rubbing and scratching the lesion and causing it to bleed, but other times it's ulcerating and bleeding spontaneously. Usually the malignant lesions have no pain at all associated with them. So what are the characteristics of epithelial malignancy? The ulceration with bleeding. Typically benign lesions do not ulcerate. Malignant lesions are fairly firm, have an irregular outline and shape. We talked about how malignant lesions are not painful. You can lose that lid margin architecture of the lashes, the anterior lamella, the gray line, the meibomian glands, and that should suggest malignancy. The telangiectatic vessels we saw on basal cells and the pearly borders are characteristic. So let's talk briefly about pigmented lesions. There are some benign pigmented lesions, the nevi, the conjunctival, compound nevus, the freckles, and the lentigo maligna. We all need to follow those, but they are typically benign. But we can worry about some other lesions. Here's a pigmented lesion, irregular, different colors, different shapes. So that's a melanoma that we worry about. Then we have a lid margin lesion. Are you concerned about this one? We can still see some of the architecture, but there's different depths of pigment, no loss of lashes out here, but we're always going to be concerned about a deeply pigmented lesion, and they can fool you and just be a nevus. So here's a different patient that had this irregular pigmented lesion on the cheek and lower lid. It was quite extensive with some very light tan pigmentation, but also darker pigmentation and almost a blue, dark black blue. The outline was very irregular, and we were concerned that it could be a pigmented lesion that was progressing to melanoma, but our pathologist called it lentigo maligna melanoma. So that can be somewhat of a stage and progress onto melanoma. We have some difference of opinions from our pathologists. Some feel like you should resect these because it's just incipiently turning into melanoma, and others feel like if you watch them closely enough, you can excise it when it does become malignant. I talk it over with a patient. I have to say I'm usually on the side of excising it, so we catch them before we lose track of them and they maybe come in. So what does this lesion look like? So it's not pigmented, it's raised, has a little bit of that pearliness. I didn't see any vessels or telangiectasias, but I got caught on this one because it's not very common, and it turned out to be an amelanotic melanoma. So you can see we can go from a pigmented melanoma to amelanotic, sort of a lentigo, which is not quite as aggressive as a melanoma, and then you can have the nevus. So melanoma can present in many different ways, but we like to use the ABCD mnemonic to remind ourselves of asymmetry. And that's because the lesion is growing at an uneven rate. And so one area might grow faster, and the asymmetry will tip us off to thinking about melanoma. We talked about the border. It's an irregular border because of the asymmetry and the color variation. You saw it can be anything from amelanotic and the regular skin pigment to different shades of black, dark brown, or light brown. D is for diameter, and that is about the area of a pencil eraser. So we worry about diameters greater than 6 millimeters. And even if we Don't think it looks asymmetric or have color variation. If it gets that large, we want to go ahead and do a biopsy. Advanced melanomas will typically be nodular and ulcerated. Non-pigmented and amelanotic melanomas mimic the pyogenic granuloma or basal cell, as we just saw. So we want to be careful and be sure we biopsy those and take care of them. You can get special stains of S100 and MHB45. Most recently, there's an MEL45 and lentigo maligna that can be useful in the histologic stains. So I'm very interested to see how the pigmentation in India affects your rates of these different tumors. So our friends who are golfers, and they may wear a sun visor, but they're getting sun on their sides, often will have these lesions. The light, fair-skinned patients, blonde and red-haired and blue eyes, with a history of one or more sunburns, UV exposures. Here in Michigan, we have very dark, cloudy winters right now. And so we don't get a lot of exposure, but then people might go to the south for a holiday and get a sunburn. If you have a history of dysplastic or atypical nevi, that is also a risk factor, especially if you have a lot of them. You can have greater than 100 normal nevi and put you at increased risk for melanoma. Not only can you have a personal history of melanoma, but if your family has a history of melanoma, that increases your rate. So even if you haven't had melanoma, but your siblings or parents have, that puts you at a higher risk rate. So it's so important to review these criteria. I'm just going to do it one more time. A new onset or recent change, maybe the lesion was just here and now it's broken out into an area in A. The asymmetric shape in B, where you see just this irregular, these little areas that have grown faster. An irregular margin where it's not nicely round, there's a little dimple there. And the different colors where you can see it lighter brown, really dark black, and a larger lesion that's greater than 5 millimeters. So we talked about this already. I don't want to get too far behind, but one thing I'd like to emphasize is eyelid and face photography. It's essential before you biopsy to take a picture of the lesion, because sometimes if it heals up very well, you can't even remember exactly where it was, even from your sketch in the chart. If your excision is almost complete, you want to follow the pictures for a possible recurrence. Let's see, sorry. So why would you biopsy? If you have any suspicion, you want to go ahead and do a biopsy. And you could do a shave biopsy or an excision biopsy. On a melanoma or a pigmented lesion, I feel very strongly you have to do a full deep excision. If it's a wide lesion, you don't have to take the whole thing, but you have to do full thickness skin and not just shave it off the lid margin. And that's because when you shave it off, you may leave some of the melanoma deep down, and then we can never get a prognosis, because the depth of the melanoma is what gives us prognosis, Clark's levels and the thickness of the melanoma. And if you shaved it in half, you can never go back and glue the two together and have the pathologist give you a height. I like to use a lid clamp if it's on the lid margin for better hemostasis. And you want to include maybe a little bit of the normal skin or lid margin, because if you just get pathology, just get the lesion, if it's ulcerated especially, then you may only have necrosis and it may be difficult for the pathologist to read. So here we have a common site with lid notching. You see loss of lashes, loss of the lid margin architecture. It's kind of ulcerated into the tarsus. And squamous cell is most common on the lid margin like this. So then this one, we saw this picture a little earlier, and it's this very angry looking lid margin. And sometimes it looks more like blepharitis, but you need to be very cautious if there's blepharitis only in one eyelid, if it's not bilateral. Then you have to be suspicious of sebaceous cell carcinoma, and we typically find it more common on the upper lids, but it's not unusual for it to go around out to the lateral canthus and extend all the way across the lid margins. So we don't need to go over this again of what melanoma looks like, but you see this almost blue color and different colors, and certainly the irregular border. So I want to touch base here on research we've been involved in and are looking at even extending it further with telemedicine. And I'm very interested to hear about what India is doing, because I have a feeling you're way ahead of us. So this is a Dermascope, and dermatology uses this a lot. They take pictures of, you can attach it to your cell phone and take pictures that here just goes right. We have an app that can go right into the patient's chart. And it's a handheld magnification, usually about 10x. We can have polarized and non-polarizing light to add to the detail of the lesion. And we can do contact or non-contact pictures. It's really has not been widely used in ophthalmology at all. Typically, the articles say that it's better on a flat surface like a forehead or a cheek, and the curves around the lids make it difficult to use. There have been a couple case studies in Europe using it on the eyelid, and we have been, we just have submitted a paper on the proof of concept of using it around the eyelid, around the conjunctiva, cornea, and potentially even iris lesions. So we developed a technique for using it around the eye and taught our staff so that they were able to take pictures for us. We sterilized the instrument with an alcohol wipe, position the patient the way we want them, attach the Dermascope to our phone, and then capture the images. So for non-contact, it's we have to get the proper distance, and we just balance our hand on the patient's forehead, and then are able to take pictures. So here is the contact. So we put a little gel on the, we first numb up the eye and then put a little gel on the contact plate. And the patient looks in whatever direction we need away from the Dermascope, and we make contact and take the picture. So we enrolled 100 patients, and there's a steep learning curve. The first few were not good enough to really read, but now we've mastered the technique and are able to do ocular surface lesions in our clinic, conjunctival pigmentation, corneal lesions. So we looked at 97 patients that we enrolled. We only really felt we had high quality pictures in about 91 of the lesions. Patients had multiple lesions. And they were reviewed by myself and 2 dermatologists who have much experience in this area. Nobody really complained of any pain or discomfort, and none of the lesions themselves were changed or damaged. Our first 20 patients didn't have very good focused, perfected technique, and we had to discard those. But then we got better and better, and our exam and explaining to the patient takes less than 3 minutes. So here we see the upper lid polarized with a non-contact, and then we also have the lesion on the surface, and we can see in the bottom picture with the Dermascope we have really good magnification with some mild pigmentation, but the telangiectatic vessels and the pearly borders. So this gives us much better photography and better magnification with details than even our slit lamp photography. So here are some of our pictures with the Dermascope. On the left top, we have a non-contact polarizing photo of a left lower lid lesion. And then we have the surface telangiectatic vessels and pigmentation, these little tiny pigment dots. And you can, which made us think of basal cell. And on the bottom, you can see we have a millimeter ruler that's in the dermascope, so we can measure fairly accurately the size of the lesion on the photograph. And then on the bottom, we see a contact polarized view again of a right lower lid lesion with very few surface vessels and sort of some subtle pigmentation of yellow and of a left lesion. So again, another picture, polarized contact photo on the right shows a conjunctival lesion with variegation of the pigmentation with some feeder vessels. And that was concerning for conjunctival melanoma. And this is a contact non-polarized with much better magnification. And you can see the vessels growing in and the variation in the pigmentation, all concerning for melanoma, conjunctival melanoma. So in conclusion, we found that this was a very good way to take pictures, and ideally, once we learn the high magnification characteristics of benign versus malignant lesions, it can reduce unnecessary biopsies. Our sample size was too small and only a single clinician took the photos, but we have developed a video where we can teach staff at off-site places and then have them send us the pictures to read about whether the patient should have to come into the main Kellogg Eye Center. So we're developing diagnostic criteria, and hopefully dermoscopy will be adopted into our teleophthalmology, which we already have, and I'm sure you do too for diabetic changes. So if I have a few more minutes here, I think we do, I'm just going to run through what I call biopsy or not to biopsy, and just think about what you would want to do on these lesions. So here's a lesion in the lashes. It's not affecting the lid margin. We, maybe the lashes are a little thin, but really no loss there. And it was a benign keratosis, as you would expect. So we'll look again at the next case. I'm just going to run through a few cases here. This was a pigmented lesion on a lower lid. It has not affected the lashes, and it seems fairly well have good lid margin and was an intradermal nevus. So let's talk briefly about treatment. Oh, sorry, these are not coming out in quite the right order. So this was a patient who had loss of lashes, loss of the lid margin architecture, and clearly had a malignant lesion that we chose to use Mohs excision. You can use either frozen section margin control, or we work with the dermatologist here and they do Mohs excision for us. And here is the defect she had. It was fairly extensive, almost 3/4 of the lid margin, not so deep vertically, but really got most of her tarsus and the lid margin. So I did a Hughes flap here where we take the upper portion of the tarsus from the upper lid and bring it down into the lower lid and put a full thickness skin graft on. So we didn't lose any of the height of the lid, which is always nice. And she had a reasonably non-red lid margin. It's always a little pink in my hands. And if you all have better suggestions, I'd love to hear them. I felt that the skin graft was a little thickened here, more than I wanted, but sometimes that's hard to avoid. So here's a basic treatment plan for a basal cell that ends up with almost 3/4 of the lid and a reconstruction. So here's another patient who had that medial canthal lesion, and that's very common. I find patients think that oh, maybe it's from their glasses, the nose piece on the glasses is irritating them, and it's really a basal cell. She underwent a Mohs excision, which is the most efficient way we've found to do it here because we're separate from the main hospital where the frozen sections are red. But you always have to think about the canaliculus and the lacrimal drainage system and if that was involved and whether you need to do a reconstruction. So one last time, summarizing our pigmented lesions, any recent change, asymmetry, irregular margins, the multiple color changes, and a larger lesion. I think we have a few minutes here. I'm going to just do a couple case presentations, just going through a history and what your thought process would be. So here's a patient with, it's a 67-year-old gentleman with a large lesion of his brow. The CAT scan showed it was localized to the right upper orbit, and the biopsy was positive for a Merkel cell. So this is a very common looking purpley dark red lesion with ulceration for a Merkel cell. We actually have a Merkel cell clinic here because it's so rare, most people don't want to take care of it, and we'll send it to Michigan for multiple specialties opinion. So this patient, because of the location, the skin and soft tissue of this right upper lid underwent wide local excision. We can't do Mohs on this because there can be extensive roots. And it was diagnosed as a Merkel cell, Clark's level 5, which is means the height of the invasion, and the depth of invasion was 21 millimeters. This also applies to melanoma. You cannot shave Merkel cells off. If they had just shaved off this whole elevated portion, then we wouldn't have the true depth and the height of the lesion. And the greatest horizontal diameter was 23 millimeters. So, and the margins were inferior margins and the deep margins were still positive. So this is another case. This is a 46-year-old woman who noticed this right lower lid lesion. And she said it started about 3 years ago and thought it had grown in size. I'm sorry, I don't have a better magnified. This is from before we were doing dermoscopy. So you probably want to biopsy it because it's a pigmented lesion that's increased in size or changed. But what diagnosis are you thinking of? So we were worried about melanoma. We thought, well, it could be a nevus, but probably, maybe not. Could be a pigmented basal cell, or it could be that lentigo maligna. So it ended up being a pigmented basal cell. And you have to be aware of both the amelanotic melanomas and the pigmented basal cells. And I have to tell you that I've been mistaken on both ends, on a pigmented amelanotic melanoma that I thought was a scar from previous surgery, and I watched the scar get bigger before it occurred to me that it probably was an amelanotic melanoma. And that can also occur with a pigmented basal cell, that you're thinking it's a melanoma or a pigmented malignancy and don't think about melanoma, or basal cell rather. So again, when to worry, we have these lesions like sebaceous cell that we worry about that have that angry red lid margin, a little bit of thinning maybe of the lashes, but mostly the injection and asymmetric blepharitis, no bleeding in this case, but loss of the meibomian glands and irregular margins. So here's a big old basal cell. So if you're ever concerned with the ulceration, you want to do a biopsy. I suggest not taking the biopsy from the middle where it's maybe necrotic, but take a little wedge from the edge and get a little bit of normal tissue so that the pathologist can compare the normal to the abnormal. If you take it right out of the center, you can end up with just necrotic tissue that the pathologist would have a hard time reading. So in terms of summarizing the treatment of malignant lesions, we've talked about margin control with either frozen sections that you have red or Mohs excision if you have dermatology here does that and reads the slides. And then their slides are sent to pathology for the formal final readings. On eyelids, I have found that in squamous cells or melanomas, that we can get away with 5 millimeter margins on the lids. On melanomas, our colleagues will usually take a 1 centimeter margin on the rest of the body, the cheeks, the scalp, but we have been very successful with just 5 millimeter margins on the eyelids. And then if it's going over the lid margin into conjunctiva, I will often do cryotherapy on the conjunctival side. You want to consider a sentinel lymph node biopsy if it's a squamous cell, a Merkel cell, or a melanoma. And then if that first node is positive, then often my colleagues in ENT do the sentinel lymph node biopsies. I do not. I've done it once and can freely give that up to them. They're way more experienced in the lymph node dissection than if it's positive. They will usually go into a neck dissection and see how many more nodes are positive. Also, radiation's an option. If you have a patient who's able to get to radiation 5 days a week for however long is determined necessary, but it's harder to tell where the margin is. You can never tell for sure. So they have to over radiate to be sure they get it all. So we typically do not do radiation here. So I just wanted to thank you for the kind invitation, and I'm eager to hear the next speaker and learn about your experiences in India. And this is the Kellogg Eye Center. You're always welcome to come visit. We have a wonderful couple here right now on a research project from Yerevan, and they've been so kind and helpful to us, and it's a great collegial relationship. Thank you. And thank you, Dr. Kim, for inviting me. This has been a great experience.
Thank you so much, Christine. It's been a wonderful talk. I think the little pearls that you had spelled out during the course of the talk was very useful for all of us.
Excellent.
Yeah, it's very useful for the postgraduates as well as practicing clinicians, because it's often that little subtle thing which actually comes out of experience, which almost always becomes a reflex for many of the experienced people. But then those pearls are some things which need to be shared. So I think there's a little difference in the type of malignancies which are common in India. What we see, I think the rest of the panelists would also agree. It's mostly the sebaceous gland carcinomas that top the list in our part of the world, followed by basal cell, and then we have very few melanoma cases. Of course, we do have, but the numbers are far lesser than what you see in the US. So,
well, I'm interested to hear about in the panel or discussion about how you manage the sebaceous cell, because that's our third on our list of frequency. So I'm waiting for tips.
Yeah, I think what I probably would suggest is, but let's listen to Dr. Santosh also, and then we'll have a round of questions for the rest of the panelists. It was an excellent talk, Christine, no doubt.
Thank you.
I think
Thank you, sir. Really, it's a wonderful talk, Dr. Christine. Very nice, wonderful. Welcome, Dr. Santosh.
Thank you, sir.
Welcome.
Yeah. Now, I think Santosh needs no introduction, at least I'm sure Christine might know about him, but then it's my duty to introduce him. He is currently the oculoplasty head for the Center for Sight, multiple hospitals across the country. And he's a very well-known, renowned oculoplastic surgeon and a great teacher. And his interest in oncology has taken the Indian forum to greater heights, and I think he's pioneering a lot of work in oncology, and we all are waiting to listen to what he has to talk about the newer advancements in the management of lead tumors. Santosh, over to you.
Thank TNOE and thank you, Usha, for the invitation. It's very hard to follow Christine. She gave a wonderful talk. I'll try my best. So I'm going to speak about what's new in eyelid tumors. And before that, I would like to just see what is the Indian perspective about sebaceous gland carcinoma. Sometimes sebaceous gland carcinoma can be a masquerade. Like these two elderly ladies who both have eyelid lesion, one in the right eye and one in the left eye. If somebody asks you which one is sebaceous gland carcinoma and which one is lesion, sometimes it's difficult to differentiate one from the other. My tip to the listeners, of course, not to the panelists, is that if a lesion were to be confined to the tarsus in a young individual, most likely it's a lesion. Whereas if the lesion were to be higher than the level of the tarsus in an elderly individual, both of these are elderly ladies, more than 60s and 70s, then likely that it is sebaceous gland carcinoma. You evert the lid and you know the diagnosis. Sometimes ophthalmologists fail to evert the lid and they miss the diagnosis. Suppose this patient were to have much earlier manifestation without this posterior lesion present, then how would you differentiate it from sebaceous gland carcinoma, lesion from a sebaceous gland carcinoma? You have to look at secondary features. We have recognized these secondary features. You can see meibomian gland orifices very crisp and nice here, but in this area where the lesion is located, meibomian gland orifices are missing. So loss of meibomian gland orifices is one good sign that you're dealing with a case of sebaceous gland carcinoma and not a lesion. In case of lesion, in fact, meibomian gland orifices would be more prominent and would be exuding. Second is loss of sharpness of the posterior lid margin. You can see how sharp the posterior lid margin is, whereas in the involved area, there is loss of posterior lid margin sharpness. The third feature is the thickness itself. You can note that this is the thickness of the eyelid here, whereas in the involved area, thickness is almost twice as much as the normal thickness. So all these, and apart from that, telangiectasia of the eyelid margin and loss of lashes would be classical signs. That's how we differentiate lesion from a sebaceous gland carcinoma. The dictum, of course, is any nodular type of sebaceous gland carcinoma can masquerade as a lesion. Recurrent lesion, if you have operated on it, or atypical lesion, atypical for age, atypical for its clinical features. In fact, having some of the features that I just mentioned would warrant a biopsy. These are some of the phases of sebaceous gland carcinoma, various manifestations, but the diagnosis is the same. Some of these are nodular, some of these are nodular ulcerative, and some of these have this kind of an appearance with which almost can look like squamous cell carcinoma, but not to miss the yellowish hue. Some of these may come with loss of lid margin because of the ulcerative nature. What can be add to further confusion is the tumor of the Zeiss gland. This is the location of the Zeiss gland, just close to the lashes, more closer to the skin. And these patients don't present with a tarsal-based lesion, but an eye margin lesion like this, which can easily be missed. The next variant that can often be missed is the pegytoid variant or the diffuse sebaceous gland carcinoma. This patient has a history of unilateral blepharoconjunctivitis in the left eye, and that's not resolved following conservative measures for a very long time, about 6 months already. Topical steroids, lubricants, everything has been prescribed to him by various ophthalmologists. This is how it looks on closer evaluation. There seems to be a lesion, vascularized lesion on the cornea. So the cornea specialist diagnosed it as squamous cell carcinoma. Obviously, do not bother to evert the lid. When we evert the lid, we see all the features that I mentioned for sebaceous gland carcinoma. You can see this is the normal thickness of the eyelid. In this area, lid thickness is almost doubled. There is loss of posterior lid margin sharpness. Meibomian gland orifices are all missing and lashes are sparse. And there is lid margin telangiectasia as well. So even a pegytoid variant of sebaceous gland carcinoma has the lid signs that are typical of sebaceous gland carcinoma. Sometimes it can be very subtle. This patient has very subtle erythema of the lid margin. That is all she has. But you can see that meibomian gland orifices stop short just in the area where the lesion is. So this is again a very early manifestation of pegytoid sebaceous gland carcinoma involving just the eyelid margin. So the teaching point here is that any chronic unilateral blepharoconjunctivitis or blepharitis, localized blepharitis, which does not respond to conventional treatment for a finite period of time, should be biopsied. And in that situation, we would do map biopsy. The management options for any malignant eyelid tumor, Christine has already mentioned very beautifully. I wouldn't want to repeat it. but we just have to, if we are using frozen section, intraoperative frozen section margin control for sebaceous gland carcinoma specifically, use 4 millimeter clinically clear margins. We do map biopsy, not in all cases, and we do eyelid reconstruction as appropriate. Specifically for sebaceous gland carcinoma, when you take the margins, it is not just from the skin side. More importantly, margin has to be clear 4 millimeter on the conjunctival side, because the tumor is often larger on the tarsal and tarsal conjunctival side. And we send the margin separately to the pathologist so that there is no confusion. Pathologist is in-house and takes about 15 minutes for reporting that margins are positive or negative. And after that, we go ahead with reconstruction as appropriate. Now, in advanced situations like this, which are more commonly seen in India, we were earlier doing orbital exentration. Of course, it is curative, but in situations where the patient has good vision in that eye, would you want to do orbital exentration in all patients? Possibly not. There are many options now, not just for sebaceous gland carcinoma, but for other tumors as well. These are the newer advances, one of which is target therapy for eyelid tumors. Depending on how the cancer is working, there are many pathways of a cancer, many phases of a cancer. Each of this, fortunately, has a marker, and each of these markers have target therapeutic agents. For example, for basal cell carcinoma, we target the hedgehog pathway. For squamous cell carcinoma, it is epidermal growth factor receptor. Inhibitors of EGFR are the ones that work. For melanoma, it is mainly BRAF, PDL1, and CTLA4. For sebaceous gland carcinoma, again, hedgehog pathway has been brought in, but it is not very clear at this point in time. For Merkel cell carcinoma, also we have a target. Basal cell carcinoma accounts for 90% of eyelid malignancies in the West, but it is very rare in India. But in situations where there is syndromic variant of basal cell carcinoma, Golden-Gott syndrome, which was described by Christina earlier, there is a target therapy, and that happens to be vismodegib or sonidegib, which is a hedgehog pathway inhibitor. And these patients, when they receive this particular drug, go into a phase of regression and stabilization. And they remain so as long as the drug is provided to them. After that, they may recur. So it's a long-term therapy that you're looking at. And in situations where the patient is inoperable, this is from the literature, large lesion involving the anterior orbit, the lesion can become smaller and get stabilized at that point in time. So patients don't need surgery, they become less symptomatic, and their quality of life is maintained by these therapeutic measures. For melanoma, for every mutation, there's a set of drugs, and many of these drugs are currently being used. You can see good results with pembrolizumab. This is published in the literature. This extraocular manifestation of a melanoma resolved very well with pembrolizumab. Even with nivolumab, there is good response. This is a conjunctival lesion, not an eyelid lesion, which we have an experience with recently. This patient had a primary acquired melanosis-induced diffuse conjunctival melanoma, and he also had regional lymph node involvement, for which he received approval for use of nivolumab. While he was on nivolumab for regional metastasis, you can see that his conjunctival lesions also completely regressed, making it a possible case for use of these target therapeutic agents for primary management of some of these lesions if they are inoperable. This is from the publication, where squamous cell carcinoma in an elderly individual who could not be operated for systemic reasons, but his right eye had severe ARMD and left eye was a potentially seeing eye. Because of the lesion itself, he has ptosis, and also the eye cornea is covered by the drooping lid. He was not able to see well. When this patient was started on erlotinib, which is very commonly available in India now, which is an epidermal growth factor receptor inhibitor, his lesion did not go away, but it became smaller and stabilized. His pupil is now clear, he's able to see well, and he lived on until he died of other natural reasons. So there are situations where you can use erlotinib. What is very interesting is for plexiform neurofibroma, which is a disfiguring tumor where, because of its infiltrative nature, surgery is very difficult. Although we use what is called a template technique, make a template of the other eyelid and try to excise and reconstruct and correct ptosis later, the results are suboptimal. This is the best result that I could get with template technique. And there is a tendency to recur as well. Now it is recognized that there is a product that is called neurofibromin. In 90% of cases, a mutation leads to loss of function of NF1 gene product, neurofibromin. And that is the reason for this proliferation. And there are many drugs that are used to target this abnormality, and these drugs are in trial. Some of these drugs have shown limited or promising success, whereas the newer advances, MEK inhibitors, have shown some better effect on plexiform neurofibroma. Of course, this is more useful for optic nerve glioma, for which there are many trials going on. Now about Merkel cell carcinoma, this is eyelid Kaposi sarcoma. You can see that these patients don't need surgery anymore. Just starting them on highly active antiretroviral therapy in this patient has completely regressed the lesion. So if you have a patient with Kaposi sarcoma, you simply have to confirm the diagnosis and have them placed on highly active antiretroviral therapy. In sebaceous gland carcinoma, we have some newer advances in terms of adjuvant treatment. This is a patient with an advanced sebaceous gland carcinoma with regional lymph node metastasis. Conventional treatment in her would have been orbital excision and radical neck dissection followed by possible radiation. But when you start them on neoadjuvant chemotherapy with a combination of 5-fluorouracil and cisplatin, regional lymph node metastasis actually regresses fairly well, and also the eyelid lesion partially regresses. So this patient, from this point on, where she would have got orbital excision, has been converted to a much limited lesion, which can safely be excised. This is one of the dramatic results that we got from chemotherapy. In this patient, there was an anterior orbital extension, as you see. After 1 cycle of chemotherapy, there was much regression. After 3 cycles, there was unbelievable regression. You can see that all the lateral part of the eyelid is all normal. All that she needed was excision of this limited tumor and adjuvant radiation, and she had a nice seeing eye. This is a recent patient that we encountered, a young patient with a very unusual form of sebaceous gland carcinoma in the lacrimal sac. Possibly it was secondary involvement of the lacrimal sac. We never could confirm that because the entire sac was involved, as well as the eyelid. Somebody had done a DCR on him, and that let the cat out of the bag. It had intranasal extension as well. Patient had 6/6 and 6 vision. So what do we do in that situation? Obviously, we started this patient on neoadjuvant chemotherapy, shrunk down the tumor, did a dacrocystectomy, and then gave radiation, and he's seeing well. And this is the final outcome of this patient. He's tumor-free for several years now. This is one more patient where there is multifocal sebaceous gland carcinoma involving both the upper lid, lower lid, and the lateral canthus, which has shrunk down considerably following neoadjuvant chemotherapy. So we can use neoadjuvant chemotherapy to our advantage when we have a potentially inoperable patient or a patient needing orbital excision, where you would really want to salvage the eye and vision. The next concept is map biopsy really necessary in all patients with sebaceous gland carcinoma? At least that is what we were taught. When we started doing map biopsy, we did it in all patients. And when we started realizing that many of these patients turn negative. In fact, in our situation, we have about 95% of patients returning with negative map biopsies. We were doing in all patients. When exactly do you want to do map biopsy? When you have a high clinical suspicion that the patient may have a pegytoid invasion, looking at the conjunctival congestion and the affection of the eyelid remote from the lesion, such as patients like this who have diffuse thickening of the eyelid, loss of meibomian architecture, loss of eyelashes in areas away from the lesion, surface telangiectasia, diffuse conjunctival congestion, and ropey discharge. These patients, of course, you have to do map biopsy. But if you have a white and quiet eye like this, it's unlikely that you will have any positivity when you do map biopsy. So you can reserve map biopsy for specific indication and not generalize it to all patients. For intraepithelial sebaceous gland carcinoma, we have identified, in fact, Jakubiak first published it, it's in his textbook as well, that there are 3 variants of intraepithelial sebaceous gland carcinoma. One is pegytoid, which we all know about. The second one is bovinoid, which classically presents with a bit of keratin, specks of keratin within the lesion, which is very typical of squamous cell carcinoma, by the way. But the bovinoid variant of intraepithelial sebaceous gland carcinoma presents with keratin. And the papillary variant, as the name indicates, has a diffuse papillary thickening of the conjunctiva. Now, what is the difference between these 3 variants is the treatment. For the pegytoid variant, nothing really works. Even mitomycin works in just about 1/3 to half the patients. And if it is a patient of this sort where conjunctiva is diffusely involved, either you excise the entire involved area if it is possible, or combine excision with cryotherapy or exenterate, because nothing else really works. Mitomycin is suboptimal. Whereas if you have a bovinoid variant, topical chemotherapy works very well. 5-fluorouracil and mitomycin work in about 70 to 80% of bovinoid variant of intraepithelial sebaceous gland carcinoma, whereas papillary responds to nothing except radiation. So this was a patient with papillary sebaceous gland carcinoma. We did everything, nothing worked, and we finally had to use a experimental radiation device, which is like exactly like this. It's like a symblepharon ring. It looks like a symblepharon ring. It is in fact fashioned like a symblepharon ring, where both the surfaces are coated with ruthenium, which can be simply placed and fixed in the palpebral fissure. So it would irradiate both the bulbar and the palpebral surface at the same time. It's not commercially available yet, but these are some of the devices that you can use to irradiate the entire ocular surface and save the eye. Next is about the concept of onchoria. Now, this is when I realized that there is something called onchoria. This patient had a eyelid melanoma, and somebody had done a biopsy before they sent the patient over to us. He had a very diffuse melanoma, mainly localized to the upper eyelid, and we had to do orbital excision in this situation. So when I was doing orbital excision, I saw that this is the nasolacrimal sac and that is the NLD. NLD was grayish in color. So there was a clinical suspicion on the operating table that the nasolacrimal duct was involved in this patient, whereas there was no tumor anywhere close to the NLD in this patient. So we chased the NLD, got the entire NLD out, did an osteotomy, went up to the inferior turbinate, got the entire NLD and submitted it for histopathology. And we found that there was a lot of melanoma cells in the nasolacrimal duct. So that obviously was a situation where there was onchoria. This patient we had published earlier had an upper eyelid melanoma, which was operated long ago, about 4-5 years ago, and later on he presented with chronic dacryocystitis. On regurgitation on pressure over the lacrimal sac, you can find that the regurgitant is curious. It's like brownish blackish in appearance. The lesion was in the upper eyelid, and now he has an NLD block and the regurgitant is brownish blackish. So how did this upper lid lesion get into the NLD sac except by onchoria? Tumor cells shed in the tear film got into the lacrimal sac and established themselves there, and that is how we presented with a lacrimal sac melanoma after several years. There was no PAM in this patient, otherwise we could have even suspected that PAM that was involving the lacrimal sac, sometimes it does, puncta and the canalicula and the sac would have produced melanoma. So lacrimal sac has access to tumor cells, and that's by onchoria. Couple of last concepts about propranolol being used in capillary hemangioma or hemangioma of capillary hemangioma of infancy. Propranolol is very useful. We all have known that this particular case report published in NEJM has received the highest number of citations ever. One case reports changed the way we manage capillary hemangioma. Oral propranolol works very well. These are all some of the good results of oral propranolol. We're not surprised, but sometimes we get bad results with oral propranolol. Like this patient did not respond at all. He did respond, but very, very minimally, and had a very high risk of developing amblyopia because of near total ptosis. Why does that happen? So we have over a period of time realized that there is a phase of growth in capillary hemangioma of infancy. It all starts somewhere close to birth, and then there is a phase of proliferation. Lesion proliferates, reaches a peak, and then it plateaus down and finally regresses. 30% regress by 3 years, 50% by 5 years, and 70% by 7 years. That's a generalization, but that's how it regresses finally. Before it regresses, it can leave irreversible amblyopia behind. If you catch a patient in the phase of proliferation and early plateauing, then propranolol works very well. If you caught a patient in the phase of plateau, then propranolol does not work well, and you have to bring in intralesional steroids. This patient did not respond to propranolol, so when we injected intralesional triamcinolone 4 mg per kg bottle, it is all that we use, one single injection, and over 3 weeks he has shown remarkable regression. Over 6 weeks is near normal. His amblyopia could be reversed. So you have to select out patients who are in the plateau phase for steroid injection, or patients who don't respond enough in the first 6 weeks with propranolol. Select them out for intralesional steroids and don't abandon this particular effective treatment modality altogether. All these patients have responded only to intralesional steroids. They did not respond to propranolol at all. What's new is topical timolol. Timolol gel forming solution can be used for very superficial hemangioma of infancy. Sometimes it even works for a larger variant. This patient resolved only with topical timolol. For venolymphatic malformations of the eyelid, of course, we inject bleomycin or picibanil now. We don't have to excise them. This is one example of a patient with venolymphatic malformation regressed with injection bleomycin. For arteriovenous malformation of the eyelid, this patient has a small AVM of the eyelid which cannot be embolized because the supplying blood vessels are rather tiny. We can do percutaneous embolization, for which we use cyanoacrylate glue, embolize the lesion, excise around the lesion, and the skin is already stretched now for primary repair, and that's the kind of results you would get. One more example of a patient where percutaneous embolization was done for arteriovenous malformation, followed by excision and reconstruction. Last bit is about vaporization of a nevus. This patient has an extensive nevus. This is a kissing nevus or a divided nevus. Excision is possible, but reconstruction is very difficult. So we have started vaporizing these lesions. Earlier we used carbon dioxide. It's not a very user-friendly kind of a probe or a delivery system that it has. Now, if you use a simple Elman apparatus, monopolar radio frequency electrode set at a particular setting, it can actually very slowly vaporize the lesion. You can see that this is after the first sitting we just did for the upper eyelid. In the second sitting, we have done for the lower eyelid, and we still have some residual pigmentation that needs to go for the third session. This patient has been completely treated. This is the patient where there is a smaller lesion in the upper eyelid and a larger lesion in the lower eyelid, and lateral canthus was also involved. This was a young girl who wanted lashes intact. She was not ready for complete excision. So here again, vaporization was performed. On day 7, you can see that the lashes have started growing back. Operative 6 weeks, you can see there is no residual lesion and lashes are fairly well grown back. So vaporization may be an option for situations of an eyelid nevus where surgery may not really help. So in conclusion, I would say that there are a lot of new strides and paradigm changes in the management of eyelid tumors. Target therapy, neoadjuvant chemotherapy specifically for sebaceous gland carcinoma, understanding of oncological principles, innovative use of glue and RF, etc., have led to much better outcomes. Thank you so much.
Thank you, Santosh. That's excellent insights we've had from both the speakers. So now I request the panelists to step in and shoot your questions to Dr. Christine and Santosh. So the first thing I want to ask both Christine and Santosh is, there's often a lot of talk around the frozen section. What if people did not have frozen section facilities? What would be your option, Dr. Christine, and then Dr. Santosh can take the answer, the question.
So I would say you could do permanent margins with delayed reconstruction. And for melanomas, we do not do frozen sections or Mohs here. Our pathologist doesn't feel that they can get good enough accuracy on frozen sections, and melanoma is such a critical decision-making point. So we will do what we call a square technique, which we've published on, where we take 5mm margins around the lesion and take a 2mm little strip and square out around the lesion. We send that for permanent margins, just close the little linear excision, and then we sort of have it set up for every week. So we will do one on Monday, and usually we have the permanent sections back by Thursday. We call the patient Friday, they come back in Monday. If it's all negative, we do a complete excision and send it for permanent margins, or we do another little 5mm margin. Maybe we got 2 sides are negative and one's, so we just keep doing it every week with permanent sections. So that would be my advice. if they don't have frozen sections as an option.
Santosh, anything different?
No, I would agree with that because you cannot reconstruct without, especially if you're using a lid sharing technique, it becomes very critical that you have negative margins. And if you don't have frozen section, then you can have rushed fixed sections. Rushed permanent sections can be available in 48 to 72 hours. They can do rapid processing. They have techniques available, pathologists, and you can ask them to do that. So 48 to 72 hours, you should have permanent sections, and it's no harm reconstructing after that.
Senthil, anything different, Senthil, that you would want to say?
Yeah, actually, like you correctly pointed out, madam, in India, we don't do Mohs very often at all. And many centers don't have access to frozen section also. So in such case, like what Dr. Santosh was saying, instead of trying to close the lesion just on gross physical examination and hoping that you'll have a negative margin, it's best to do it as a two-phase surgery. You first send the sample and don't do the primary reconstruction. You wait for your histopathology report and then plan the reconstruction in a separate day so that you are at least sure you have clear edges. Because once you reconstruct, then it's again difficult for you. If you have a positive margin, it's again you have to, especially for the lid sharing procedure, I think you're in a very sticky position. So I think the take-home point is do it as a two-phase procedure if you don't have access to frozen section.
So the next question I would like to ask Christine is, how often do you biopsy before you completely excise?
So in general, our policy here is to almost biopsy all the time. So often it's helpful if we're doing frozen sections for the pathologist to have the sample of a permanent section to look at and compare. So they find that the frozen section is not as nice a slide to look at. So that if they have the biopsy slide, they can compare. Our radiation department will never do radiation without a biopsy. Even if I've done something on one side and it looks next year they get one on the other. Nope. So I don't know if that's the legal cultural situation here, that if we, and I tell the patient if it comes back benign, well, that's wonderful. I had a patient that I didn't do a biopsy in. He was an older gentleman, a little, I couldn't do the biopsy in clinic, so it was going to be a bigger deal. So I said, well, it was a lid margin, and it ended up being a nevus. But, and I did a lid, and just closed it. And so no harm, no foul, but I could have easily just done a smaller biopsy and saved him that. But I couldn't do that in the office. So I guess here with, we have too many lawyers, so we always do a biopsy.
What is it with Santosh?
I would excise it. If I want to excise it, I wouldn't do an incisional biopsy. I would rather excise it if I have a doubt between a benign and a malignant lesion. If a benign lesion deserves excision, and if you excise it, and if you think that it could be a benign lesion, I would get an intraoperative diagnosis. And if it is malignant, I would go ahead and excise additional margins and subject that to frozen section and close it on the same day.
Vijay, do you have anything different to say, Vijay?
No, ma'am, I also go with Honover sirs and what you say, but I just want to know which all cases would Dr. Christine advise most micrographic surgery? Which all cases would they want to do that procedure? Is it for all or only for certain cases like sclerosing of morphia forms and medial tumors, medial canthal tumors?
So for the Mohs,
Yes.
surgery, I'll never do a melanoma on Mohs. Sebaceous cell, we don't do Mohs. They'll do squamous cell and basal cells, but I'm interested, would you ever do that on a sebaceous cell? Merkel cell, I would not do Mohs. So I think it's mostly for basal cells and sebaceous cell, basal cells and squamous cells.
Okay.
Is Shruti around? Shruti, do you have
Yes, ma'am, I'm here.
Do you have anything different to add?
No, ma'am, I think it is pretty much same as like what Dr. Santosh and Vijay and Dr. Christine said. If the lesions are very, very typical, like it is, if I'm very sure of the diagnosis that it looks very typical of a malignant tumor, I would go ahead and do a diffus sitting itself. I wouldn't really subject them to an incisional biopsy. But if I am a little bit unsure, and if it looks more benign, and then where I don't really want to excise more lesion and be more, removing the 4 mm and all that, then maybe sometimes I do an incisional biopsy. But most oftentimes I would go in for an excision.
The next question I would like to ask Christine is, in a case of an inoperable basal cell carcinoma, what are the options that you would think of?
So I agree with Santosh that I would use the average, and I have had some patients, and we did a study looking at them and just either organ saving or life saving. So I have a young 50-something patient who doesn't want an exoneration, and the basal cell had extended back, and it's very hard to follow because we can't see much of it. I excised as much as I could, and then the posterior margin was still positive, went back again. And then margins were never negative enough for me. So I always felt like I had a tumor left. He didn't want an exoneration, and this has been a way I followed him for over 10 years. So that was sort of his choice. It wasn't life-saving, but he was a salesman, so he felt that he needed to look presentable. And can I ask a question of Santosh and the other panelist?
Yeah.
So
Yes.
I have a question about your Elman for the nevus of Oda. So I have an Elman and I have patients, but I've never done that. Could you give me more details, like exactly what I would have to do if I had one next week?
Well, I use a 810 needle, and I use the side of the needle, and I use a setting. I very gradually increase the setting. I put cut at 0, and I put coag at about 6, and start increasing it to in steps of 6, 12, 18, and roughly between 12 and 18, you would get a good vaporization. It just melts away.
And what kind of needle was that again?
810 needle, 810. 810 needle. Yeah, 810 needle, and the side of the needle is what I use.
And so you're just vaporizing, you're not excising at all?
No. I of course, I take a sample for pathology. That's mandatory because that's medical legal. And then rest of it is vaporized.
Have you published that?
No, I haven't. I'm collecting cases.
Yes, because I don't know anything about that. I might have to call you before I try it.
I'm too lazy to publish, but I would get there someday.
Yeah, so the next question, Manik Shah, I think he's got a lot of experience with rhinosporidiosis. Can you share your Manik Shah?
Yes, ma'am. Rhinosporidiosis we are getting. Here it is epidemic in our nearby district, Kanyakumari district. It is very common, rhinosporidiosis. So rhinosporidiosis of the conjunctival lesions as well as lacrimal sac, we are getting most of the rhinosporidiosis. And one peculiar thing is rhinosporidiosis, there's typical history will be there. They are taking pond bath. That is the most common typical history. And even by clinical examination, most of us are able to identify the rhinosporidiosis. One thing what here we are doing is, we are doing histopathological examination of the discharge from the lesion, from lacrimal sac. We are collecting the discharge and we are immediately doing gram stain. That will give the rhinosporidiosis organism. Then we will proceed for surgical management. So that will help us. Even pre-operative lacrimal sac rhinosporidiosis, most of the time we can able to diagnose intraoperatively. But pre-operatively we are able to diagnose it, and we are able to treat that lacrimal sac rhinosporidiosis.
I think it's very interesting that we've had two situations, one which Santosh was talking about, melanoma getting into the sac, and the other one, rhinosporidiosis. Very interesting scenarios. And Dr. Manik Shah from Tirunelveli actually borders the state of Kerala and has a lot of ponds and water logging there. So people tend to take bath in these ponds, and thanks Manik Shah for that insight. So any other questions from the panelists?
I have a question for Dr. Christine. The Dermascope that you use, how often are you able to differentiate between melanoma and any other lesion when you're using the Dermascope? Are you able to say for sure before biopsy that this could be a melanoma?
Not yet. We're just, we're in our second phase. So the first phase was just proof of concept because everybody said you couldn't do that. So now we are actually taking pictures, looking at pathology, having the clinician predict what it is off the picture, and then comparing with the pathology. So you'll have to stay tuned. It might take us another year. I'm behind Santosh in writing papers, so it might take us a little bit longer, but maybe we can, if we find anything, but we're not at that level yet. I'm still learning from the dermatologist on how to interpret the skin basal cells. They have a whole book published on all the different Dermascope changes to look at, you know, and they'll say, oh, you might find gray, and I don't even see gray, and then they'll point it out and I can see it. So it's still very, very new, but I have learned so much. Santosh, your sebaceous cell talk was fabulous. We don't see very many, and just to see your pictures and the variety, and I was fooled on every one of your subtle ones that you were showing with the chalasia. That was so important to me that I learned a lot. Thank you very much.
Any other questions from?
I have another question to Dr. Santosh. So when you are when you chemo reduce these patients with sebaceous gland carcinoma, they reduce by almost 70%. And when you are excising them, what special precaution do you take? Do you take the same 4 mm, or you know, because we are not very sure of the margin clearance even after you chemo reduce?
Yeah.
So what do you do for those cases?
I take wider margins. I take about 6 to 7 millimeter margins.
Okay.
Initially, I took 4 millimeter and I found margins positive. So I started taking 6-7 millimeter margins, and sometimes based on clinical suspicion, you know, it might have reduced in bulk, but when you look at the patient on slit lamp, you still find meibomian gland dropouts in the adjacent area. Beyond that, I go about 6 millimeters. So it's huge reconstruction, but it's worth it because their eye is not involved at all. It's the lid that's involved. So you're able to save the eye and vision.
So do you take the patient to the slit lamp before you operate and mark?
Yes, absolutely. Okay. Mark with a marker pen, exactly.
Yeah,
the
and then
clinical
take
extent.
them to the operating.
Yes, beyond. Yes.
Okay. Yeah. Excellent tip.
I have questions for all the panelists now. How many times have you thought that it was definitely a malignancy and have been deceived? Christine, we'll start with you.
Say that again.
How many times have you thought that this is definitely a malignancy, but then have been deceived? How many cases? Did you ever have a situation like that?
Well, I'm not sure I would say I definitely, but I was highly suspicious. It's the one I didn't do the biopsy on, and then it ended up not being malignant. But nobody was sorry. I just said, you know, that's the good news, that there was no malignancy.
So how about Viji? Did you have any situation you can share?
No, ma'am. I think mostly like what the tips Honava sir said, thickening of the margin and loss of meibomian gland orifices and the involvement of the tarsus. So I think those are, I mean, by that, you know that there's definitely a malignancy, but many times when we have to assure the patient that it is definitely a malignancy and not a benign, then we sometimes have to do a biopsy before telling them that they have to undergo some major reconstructive surgery. We cannot just tell that it's you know, benign or malignant. So just to convince them, we have to sometimes do a biopsy to tell the patient and then go for a major reconstructive surgery, especially when we're going to do a 2-stage technique.
How about you, Manik sir?
Yes, yeah, I also agree with Viji, but I have come across few young patients around 30 to 34 years. Initially, I was thought it is Galatia. I removed INC then, but after 1 month, they came with recurrence. Then only I suspected, then I did a biopsy, then it confirmed as. So we are not always correct, sometimes misleading also.
Yeah, that's the news we'd like to give for the non-oculoplastic surgeons. I think Atik is not blinking, so yeah, Shruti, any
It is bored.
Yes, ma'am, I have had. And always, like, even if sometimes lesions, they can be quite deceptive, but whenever I curettage and if I feel that the curettage is not very typical, then I would essentially send it for a biopsy. It is that's mandatory that I do. And yes, I have had sometimes which looks like just a nevus, but then it has turned out to be a malignant lesion. Yes, I've had that. I have had lesions where referred from elsewhere with query pegatoid spread, query with a lot of lesions all over the conjunctiva on the lid margin. When I've done a biopsy, it had turned out to be just non-specific inflammation. And one particular patient I remember, which was like this, and it was like, the whole lid margin was inflamed. I've had two patients like that, which says as when I took the biopsy, non-specific granulomatous inflammation, you give them steroids, you give them anything, it wouldn't really go down. And I had to inject them with alpha interferon 3 times, and with 3, they've disappeared completely. So I really am clueless what the diagnosis was, but ultimately they responded well to alpha interferon. So I really don't know where you can take one step ahead of, the uses of alpha interferon. Are we really using it less or more? I don't know. Are we using it or abusing it? I don't know.
And also, ma'am, we have seen many cases of ocular cicatricial pemphigoid being treated with topical immunosuppressives, but finally they don't resolve, and when we do a biopsy, it comes out as a malignant lesion. There are many cases which have been missed like that.
Sendil, any?
No, madam. Most of the times, I have not had any surprises because most of the time it's been reversed. Sometimes you think it's benign and you just do a routine biopsy, and sometimes you're surprised that it has come as a malignancy, because our threshold to biopsy is very low. Anything slightly suspicious, we do a biopsy quickly. We don't wait.
Santosh, about you?
Yeah, I have had occasions. Yeah, I have, in fact, I put it as a form of a lecture. Few cases where thought it is benign and turned out to be malignant, and vice versa. That happens. Atypical situations are many. That's why you depend on the pathologist, and they have the last say anyways.
Yeah, I feel so reassured now. I feel confident because I just had one case recently where I almost thought it is malignant and was proudly teaching my fellow, and it turned out to be Demodex.
Wow.
Yes, it was shocking. I was almost sure that it was an STC because the way it had presented. So I've asked, in fact, it's today I was pleading with my pathologist to give me a hint of a STC, please, because I don't believe that my clinical diagnosis went.
It happens even with surface tumors. I've had surface tumors like that, which I'll be so sure that this is OSSN, but it turns out to be something else. And same situation I had last week. I was telling my fellow, this just doesn't look like OSSN at all. And then when I did the biopsy, in fact, I didn't even do cryo because I was so sure that this is not, but then it turned out to be OSSN. I don't know. Yeah, it can happen.
All can be reassured that we can slip, Yeah, the next question I have, I think probably I would ask Christine about squamous papillomas. How have you handled?
How have I what?
Handled the papillomas?
So they can be very challenging because I've had some inverting squamous papillomas going down the nasal canaliculus or coming the other way up the nasolacrimal duct. And in those cases, I'll work with my ENT colleagues because I think you have to get rid of it or it'll just recur.
How about you, Santosh? Any experience?
I excise them and do base cryotherapy. And you can inject interferon at the base if they're not excised.
Sendil, any thoughts?
Yeah, same thing, madam. I also excise and
Any
Dr.
other
Ayo.
differences? Aviji or Shruti?
No,
I
ma'am.
excise it, madam. I also excise it.
I cauterize the base.
And Maniksha?
Yes, madam. I also exercise and cartridge this.
So I think we are coming to almost the end of the session. It's been
Can I have one question to Dr. Santosh?
yes, of course.
Last question, if you permit me. For capillary hemangiomas, you inject just triamcinolone, or do you combine triamcinolone with dexamethasone?
I inject only triamcinolone. In fact, we don't have to fill the lesion. It's low volume and just confined to the dose of 4 to 6 milligram per kg body weight overall. Didn't ever have to mix with dexamethasone. That just increases the volume, that's all. Because dexamethasone really does not work on capillary hemangioma so much. You need a sustained kind of a drug.
I think there are variations in this. I do with Dexa, more for volume, as I said. And yeah, I think it works both ways.
Madam, can I just ask one question, if you permit me, to Dr. Santosh?
I can ask one last.
Yeah. Santosh, sir, I have one question. For meibomian gland carcinomas which are spreading extensively onto the globe, you said you have so many other modalities of treatment, and you experiment with them. What is the risk of systemic spread by not doing an excision in these cases, where we have extensive spread onto the globe? By not doing an excision, is there any increased chance of systemic spread?
No, systemic metastasis sebaceous gland carcinoma is very rare and late. So maximum it would go to regional lymph nodes, but we don't wait on those patients. Even if you start on topical mitomycin, maximum you would wait for 6 to 8 weeks. And if the patient is not responding, either you go ahead with orbital excision or do something else which may be more curative. Kind of, you don't wait on them for several months. It's 6 weeks to 8 weeks that you would look for response.
Okay.
Any other questions? Christine, anything?
No, I just want to thank you for including me, and all the panel, and Santosh for his wonderful talk. I feel like we just don't see that many, so it's just so enlightening to see your slides and hear your clearly more careful, refined examination of those patients. So I learned a lot from you. Thank you.
Thank you so much. Now I'll have to pass on to the president and the secretary and the scientific chair for their comments.
Well, good night to you. It's still morning to us.
Sir is not.
RK sir, you're muted, sir.
RK sir, we can't hear you.
RK sir, I think you'll have to unmute.
No, he's not muted, ma'am, but for some reason I can't hear his audio.
So I'll voice out for him. Thanks
Yes.
to Dr. Christine and Dr. Santosh for the excellent talks, and the panelists for all their insights. I think it's been a great evening, though a very short one. We would have loved to have an extensive session. Thank you so much. And thanks to the president, secretary, and the scientific chair for being so patient with us, because we didn't let you speak at all. Or ask questions. So thank you.
And Usha ma'am, thank you so much for wonderfully coordinating the whole show.
Thank you. It was a pleasure. Thank you. Thank you, Manjula and Sai, for the excellent display. Thank you so much. No technical.
Thank you.
Thank you, madam. Thank you so much.
Thank you, ma'am. Thanks for amazingly a great panel discussion. And Santosh sir, as usual, amazing talk. Thanks, Ramakrishnan sir, for getting ma'am. Wonderful talk. I think there'll be a lot of views in YouTube later on. Thanks to all the panelists, Maniksha sir, Sendil sir, Shruti madam, Viji madam. Thank you so much, everyone. Thank you.
Thank you. Thank you.
Thanks to Numerotech and
Thank you.
Oro Lab.
Thank you.
Thanks, Krishna also. Thank you. Thank you.
Thank you, Vishal.
Thank you, madam.
Thank
Good
you,
night.
madam. Thank you, ma'am.
Good night. I think RK sir is not audible, but I'm sure he's
I think we'll call him and talk to him after this is over.
thanking us. I can hear his mind voice. He's
Mind voice.
profusely thanking all of you for being here. Thank you.